The following is a paid advertisement of St. Anthony Hospital Orthopedics. References to any specific product, services, or entity does not constitute an endorsement or recommendation by St. Anthony Hospital, Carroll Broadcasting, or its advertisers. The views expressed by the host or guests are their own, and their appearance on the program does not imply an endorsement of them or any entity they represent. Welcome to the St. Anthony Hospital Orthopedic Show with Dr. Richard Godding. Dr. Godding specializes in joint preservation, reconstruction, and replacement surgery, and brings over 25 years of orthopedic excellence to St. Anthony Hospital and to the Carroll area. For more information about Dr. Godding, his practice, or St. Anthony Orthopedics, go to santanthonyhospital.org or make an appointment by calling 712-794-5536.
Good Sunday morning, Iowa. It's Dr. Rick Godding here. Thank you very much for spending a little time with me here. And I guess it's a reasonable time to talk about ligament and tendon injuries. If you watched the Indiana Pacers final game, you saw that devastating Tyrese Halliburton injury, which at this point on recording, I don't have official news that it was a rupture of his Achilles, but boy, it sure looked like it. And so just talk about tendon and ligament injuries. It's something I don't really talk about it much, but it's that time of year. It's, a couple months here. I'll be doing football. There's summer baseball going on. There's summer wrestling. So let's start with what is a tendon and what is a ligament. What are the differences there? So a tendon connects bone to muscle. So the quadriceps tendon is an interesting one because it's the tendon that attaches the thigh muscles, the quadriceps, right, through the kneecap. The kneecap rides in the middle of this tendon and then attaches it to the front of the tibia or the shin bone. And that's when you shorten your quadriceps muscle by flexing it, your knee extends, so your leg goes straight. So it's an interesting naming, this one, because the quadriceps tendon does indeed attach the quadriceps muscle to the patella bone, but then the patella tendon, that's the only one that attaches bone to bone, and I don't know, it's kind of like splitting hairs, but the patella tendon goes from the bottom of the kneecap to the front of the tibia. And they are unique structures. You never really tear both. So injuries in this area, you either will break your kneecap, and then that will pull apart, and then both of those tendons are intact, but the kneecap itself is broken, and then that needs to be put back together. Typically, we do that with screws and sometimes wires and thick sutures. But you can rupture it on the quadriceps side, so above the kneecap, or on the patella tendon side, so below the kneecap. That's one, you don't see that a lot in athletes, and you can see it in football. I've seen a few in football, but most of the time you see those in a person who, where I've seen them the most is somebody who might be a little deconditioned or older and is playing a sport or doing an activity that was a little above what their body is really set up to tolerate at that time. Trampolines, 50-year-old guys on trampolines, I've seen a few of those. Softball is a big one. And of course, softball, you have somebody who might not be in super duper shape and then is going to round the bases as fast as they can, and sometimes that'll blow it out. Now, when you exercise, the tendons and ligaments in your body get stronger. Okay, it makes sense. The reaction to that. So your muscles get bigger and stronger if you exercise them. Well, your tendons and ligaments get bigger and stronger too. They actually will grow in size and thicken up and become stronger in response to exercise. So tendons attach muscle to bone and ligaments attach bone to bone, except for the patella tendon, which is really a ligament, but we're splitting hairs. So we'll stay in the knee, and then we'll get back to the Achilles in a moment. Now, the mechanism, though, for a lot of these is what we call an eccentric contraction. So an eccentric contraction is exactly what happened to Tyrese Halliburton. What that means is your muscle is lengthened and the tendon is lengthened. So if you watch the replay on that, his foot is all the way back and then his calf muscle is flexing. So in the face of a force that's already there by virtue of the angle that the joint is at, plus you add on the extra force of the contracture because the calf muscle is trying to shorten. And that's how he ruptured his Achilles. The same thing will happen in the quadriceps, either the patella or quadriceps tendon, or the third way, like I talked about, is the patella fracture itself. That typically will happen with an eccentric contraction. That's what we call those. So muscle is fully lengthened, tendon is fully lengthened, and then muscle contracts in addition to having a force applied. So if you're falling off a ladder, a couple feet, if you fall off a high ladder, all kinds of crazy stuff. If you fall down a step or two, your knee can be bent a little bit, so your quadriceps muscle, or your Achilles for that matter, is lengthened a little bit, and then as you're trying to land, you have the impact of your weight, and in addition to that, the force of the muscle pulling. All those things end up with a rupture. So let's finish out sort of the ligaments in the knee, the main ones. There's more smaller ones that have some contribution, but mainly you have the ACL. Everybody's heard of the ACL. Oh, they tore their ACL. That's anterior cruciate ligament. Cruciate means cross-shaped. So there's an anterior, means in front, and a posterior means behind. Typically don't see the posterior cruciate ligament tear, but it can tear. Oftentimes when it does tear, it's not isolated. In other words, it's maybe a dislocation of the entire knee, which is not the same like a kneecap dislocation, but the entire knee just comes apart, and that's a real high energy trauma. But the anterior cruciate ligament, the posterior cruciate ligament, the medial collateral ligament, that's the collateral means on the side. So the medial collateral is on the side of the knee that is facing the other knee. So if you touch the inside of your knee, you'd be touching your medial collateral ligament. And then on the outside, which would be facing 180 degrees from that, directly opposite of that, is the lateral collateral ligament. Now, the medial collateral ligament, just by virtue of how the anatomy works and how forces are applied, the medial collateral ligament is more likely to be torn than the lateral collateral ligament. So if you tear your quadriceps tendon, you have to repair that. I talked about repairing the patella if that fractures, and then if you tear your patella tendon, you have to repair that too. A lot of different techniques. Mostly it's just suturing it together in a special way. The medial collateral ligament, if it's a very bad tear, then you do have to fix it. But most of the time those aren't bad enough, and you just wear sort of a knee brace that keeps your knee from moving side to side. You can move it front to back, but it won't move side to side. And usually 6 weeks in that will take care of a medial collateral ligament or lateral collateral ligament tear. The anterior cruciate ligament, now this we reconstruct instead of repairing. So what does that mean? That means we either take some of your own tissue or take a donor tissue from cadaver donor and basically drill the holes and thread that back up where the other one was going to begin with. So it's a reconstruction. You don't have an ACL repair. Now, there are some newer techniques of repairing the ACL, but it's not very widespread. The gold standard is to reconstruct it, in other words, to put a new one in. And typically what we will do is in a younger patient, sometimes you can use their own tissue. As you get older and older, especially if you're over 30, sometimes it works better to use donor tissue because you can have what they call donor site morbidity. So donor site morbidity means wherever you took that piece of tissue from the person, if you're going to use it on their own knee, like you can take the quadriceps tendon or the patella tendon or the hamstring tendon, and you can use that to thread it back through to reconstruct or replace. We call it a reconstruction, but you could also call it a replacement. The anterior cruciate ligament. And the posterior cruciate ligament, same thing. I like to use the cadaver in whatever age because I just think I think there is a thing called donor site morbidity, and I think people do perform better if you don't harvest their own tissue for that particular reason. So those are the ligament and tendon injuries about the knee. Now, we're not talking about the meniscus. The meniscus is a cushion inside. That's a different discussion. But I'll just mention it since we are in the knee, and meniscus tear is a very, very common injury. The meniscus or menisci, there's a medial and a lateral, because there's a medial side of your knee and a lateral side of your knee, the inside of the knee and the outside of the knee. Inside being facing the other knee, outside being facing 180 degrees from that. So when the meniscus tears, 95% of the time, you take out the torn part and you do not repair it. So many times I have patients come in and say, I had a meniscus repair. Almost never. Only, number one, if you're under 30, you would not repair a meniscus in somebody over 30. They just don't heal well enough. And number two, only if you catch it early and you have a very, very particular type of tear. It has to tear on what we call the red-white border. So if you tear in the middle of your meniscus, we can't fix it. So that's the knee. So let's move down to Tyrese Halliburton's unfortunate Achilles, what appears to be complete Achilles tear. So the Achilles attaches the calf muscles. That would be the gastrocnemius and the soleus are the calf muscles, and the Achilles attaches those to the back of the heel. And when you flex that muscle or shorten it, when you flex a muscle, you shorten it. But by definition, you're shortening that muscle. That's why you have that action through the muscle. So you shorten the calf muscle, and that pulls the Achilles up, which pulls the heel up, which pushes the front of the foot down, because the foot acts. There's a lot of joints in the foot, but they don't have a lot of mobility. So if you pull on one side of it, just like a teeter-totter, it's going to go down. So to pull it up, you have a couple of other tendons, but they're not nearly as strong, because when you're pulling your foot up, you're just pulling the weight of the foot up. I mean, you're not. But when you pull the heel up, you're pulling your whole body weight up, if that makes sense, because that's how you're walking. So now, Tyrese Halliburton had a calf muscle strain. There's not a direct correlation between calf muscle strains and Achilles tears in the literature. In other words, you don't see, that's not taught as a correlation point. But boy, I mean, common sense dictates that if that mechanism back there is injured and then you injure it further, that there is a susceptibility factor there. So how do you treat an Achilles tear? So in an athlete, you're going to fix it. Which means you're going to suture it together. You're going to tie it together with sutures. Sutures are just medical grade thread, if you will. If I tore my Achilles, I would not have mine repaired. I would treat mine in a cast, and I would treat most people in a cast. Now, you can lose a little bit of power by doing that, but it's more like 5%, and I don't do anything that 5% power is going to make a big difference. But, for a professional athlete, 5% is big. It's a lot. So you definitely would fix the professional athlete. The other thing is in the older patient, and I would consider myself getting there at 55, there's a higher rate of complications because you're making an incision right where there's just basically skin over that tendon. I mean, there's no big fat layer under it. There's a little tiny bit, but nothing significant. So we do see wound healing complications. And as you get older, things like that don't heal as well. So I would err on the side of caution for that, for myself and for my patients, and go ahead and accept the 5%, maybe 8% loss of power, which isn't really going to be noticeable in somebody like me, whereas Tyrese Halliburton, it would. So the other sort of major ones, you can pull a hamstring, you can tear a hamstring, you can tear your hamstring off of your pelvis bone where it starts, or you can injure it more distally, meaning farther away, where it inserts, and it actually inserts down on the tibia. It goes past the knee, but most of the ones that are bad are up higher, so where it's coming off of the pelvic bone. We talk about the origin and the insertion. So the pelvis bone is the origin of the hamstrings, and that can be problematic. It can tear all the way off. So if that does, then you probably need to get it repaired back on there. But most of the time they're partial tears, and most of the time we don't do surgery. I have never done a hamstring surgery, and the couple that I've seen, I just send to somebody who does a lot, because if you're not doing a lot of something, I don't think it's easy to stay good at it. And the other that I see lots and lots and lots of is rotator cuff tears. Now, rotator cuff tears, of course, are tendons. The rotator cuff is tendons because they attach the muscles, the deep muscles in the shoulder that move it around, that rotate it. Those muscles attaching to the bone is the rotator cuff. Now, those sometimes you will see traumatic. Somebody will fall and either down onto an outstretched arm, or they'll fall and they'll grab something to catch themselves and they'll pull. But most rotator cuffs tear because they kind of wear out over time. And that has to do with the blood supply of the rotator cuff. Specifically the supraspinatus. There's 4 tendons: the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. The supraspinatus is the top one, and that is the one that typically will tear first. Although sometimes the subscapularis will tear first, but most of the time that's the one that tears first and tears the biggest. The blood supply to that insertion of that tendon onto its bone is not great, and so therefore it tends to tear there. And again, you don't have to fix it, but if you don't fix it, it gets worse and worse and worse. The humeral head can ride up and start rubbing on a bone on the acromion process of the shoulder blade, and that gives you what's called rotator cuff tear arthropathy. And people can actually go so far as to have what we call pseudoparesis, where their muscle's not paralyzed, but they just don't have any connection anymore, so they can't lift their arm up. And that doesn't always happen, but it can happen. And those are kind of the big ones that you see that are real problem tendon and ligament injuries. I mean, there are a few in the hand and feet that we could go into. Mallet finger is one where the tendon will just pull off the bone, and then you're not able to extend your fingertip. And there's a thing called the Lisfranc injury in the foot that's very complex. But when you sprain your ankle, you're stretching those ligaments, and you can go as far as to tear the ligaments on the inside of your ankle when you sprain it. So ligaments attach bone to bone, tendons attach muscle to bone, and there's ligaments all over. There's tons of ligaments in your spine. There's ligaments in your hands, your elbow, wrist. Sometimes you'll see the biceps can tear, and the biceps can tear either from the shoulder side or from the elbow side. We don't do anything when it's from the shoulder side because there's actually 2 heads of it that go up, and when you do tear the one head, it's always the long head, and it's very hard to get down and get it back once it's torn, and it doesn't really cause a lot of problems, so we don't do much with that. However, at the elbow, we do fix it because you can lose up to 40% of your strength. There's a lot of these little nuances, and there's ligaments all over your spine. Like I said, there's ligaments in your pelvis. There's ligaments anywhere that 2 bones come together. There's going to be ligaments and tendons as well for the motion, although the anatomy is very complex and varied. But those are the big ones that we see. Sort of athletic and work injuries is the quadriceps mechanism. That'd be either the quads tendon, the patella fracturing, or tearing of the patella tendon, which attaches the patella to the tibia. And then the medial collateral ligament, lateral collateral ligament, anterior cruciate ligament, posterior cruciate ligament. These are all injuries, variably common. Most common would be the MCL and the ACL. And then the Achilles tendon and the rotator cuff. Those are the big ones that we see that we ended up doing a lot of surgery to fix. So I just thought, I feel bad for Tyrese Halliburton. That's a tough thing. He seems like a real decent guy, and obviously proud Iowa State grad and all that. So hope for a speedy recovery for him, and we'll see how that goes. But that's my little ligament and tendon brief lecture. So thanks for tuning in, and you have a blessed week, Iowa.
This has been the St. Anthony Hospital Orthopedic Show with Dr. Richard Godding. For more information about Dr. Godding, his practice, or St. Anthony Hospital Orthopedics, go to www.santanthonyhospital.org or make an appointment by calling 712-794-5536.